And so what I'd like to spend the time doing today is one, just talking about the umbrella term that is elder mistreatment, and how that encompasses forms of mistreatment, including various forms of abuse, neglect, and financial exploitation, while supplying you guys with information that will allow you to identify either signs or even just risk factors before. I mean, ideally, we're doing primary prevention, we're preventing it, and we're seeing the harm that could happen and who might be vulnerable for experiencing elder mistreatment, because as you will see soon, the numbers are quite high, and we are probably encountering it far more often than we recognize or even know. So I hope to help in that. Also want to talk just briefly about like legal responsibilities of healthcare professionals, while acknowledging that that does vary state to state. And so I did include what I could find on North Dakota's regulations about that, but also understanding that, what a mandatory reporter is does vary a bit depending on where you are. Talking about how and why to use APS and kind of what we can expect from them. And then just in a very kind of casual way on the slides, including nods to the 4Ms framework that was put up by the Hartford Foundation, Age-Friendly Health Systems, in conjunction with the Institute of Healthcare Improvement, or IHI. Some of us might have done modules with them as well. But you'll see like those little circles appearing at the bottom of some of the slides just to give hints about like what might be a risk factor or what it might impact based on the mistreatment subtype we're talking about. Okay, so it's always good to have common language, but admittedly that can be very, very hard because even within the field of elder mistreatment, the terminology we use is varied. Many people just say elder abuse as the general term and then further delineate. Some say elder abuse and neglect. There's a lot of ways to say the same thing. And then moreover, there's the whole variety of like institutional and organizational definitions, many of which are very ivory tower to our patients. And so, kind of recognizing that although there are, formal definitions, this might not be what any of our patients or people from different cultural groups define these things as. There's a lot of really interesting research about, like the impact of having someone who looks to be from a similar cultural or ethnic background or racial background asking a question to a patient of a at least superficially similar background, and how that can influence reporting versus like, if maybe I as a white female ask the question with all, my fancy sounding academic titles. All of that really matters. But again, for sake of argument, if we look at the World Health Organization's definition as compared to CDC or National Institute on Health or aging, they define mistreatment as a single or repeated act. So it involves an action or a lack of an action. It's not just something you think. You have to do or not do something, or the perpetrator, the person having those mistreating acts. They must do or not do something in the context of a relationship where there's an expectation of trust. So it's not, I can't neglect someone on the side of the road, assuming I'm not a physician and bystander laws don't apply. I can't just neglect someone by not feeding someone who is unhomed. I'm not neglecting them. I don't have a relationship or with an expectation of trust. But regardless, this action or lack of action in a relationship, at least according to the WHO, needs to cause harm or distress to an older person. And I kind of take a little issue with that because although I'm on the taller side, I'm not built very largely. And my experience in life playing around with people is that I don't know how to throw a punch. I'm not physically very strong or robust. And so if I were to try to hurt someone, which of course wouldn't do, but if I were to trying to hurt someone and it didn't hurt them because again, I'm not talented physically, That doesn't matter. I still try to harm them. There was an intent to hurt. And in many of the legal definitions, intentionality really matters regardless of resultant harm. So I kind of wonder about the World Health Organization's definition. But I pointed out not to, say anything negative about the WHO, but to point out that again, these definitions may or may not actually encapsulate what our patients are experiencing. So it's important to talk to them where they are using the words and their understandings rather than, kind of getting stuck with pie in the sky, fancy definitions. Another reason to talk to our patients and the people we take care of as they are is that many, 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 as in like 1 in 2 or 50% of the people that we take care of that have a cognitive impairment or a dementia of any cause, of any variety, 1 in 2 of them will experience elder mistreatment over the course of their life. So that's a coin flip. That's like half of, if you see patients in a clinic, that's half of your patients each day in clinic who have cognitive impairment are going to have experienced elder mistreatment. If they don't have any cognitive impairment, and we got to be sure we're screening appropriately for that and not missing that too, it goes down slightly, but still to an alarming 1 in 10. So again, in a typical day in clinic, you might see 1 to 2 people, if no one has cognitive impairment, who have experienced elder mistreatment. And anyone who does anything in geriatrics knows many of our patients do have a cognitive impairment. So the numbers are exceedingly high, but most of them are not being reported. An estimated 1 in 24 cases. So like what, like 2, 3%, um, you know, 4%, something like that, are being reported. Not nearly enough. So it behooves us to one, screen for cognitive impairment because that's an important risk factor, but two, to ask these questions specifically. So we'll talk a little bit more about what we should be doing soon. But first, we kind of got to learn what we, what do we think we're seeing? And so this is where the poll everywhere can come in handy. And basically it's multiple select if you've seen more than one, but I'm curious what you guys are seeing in your practices and in your professional experience. We'll just let those numbers come in. We'll give it a couple seconds. Good. Lots of answers. I appreciate it. It's nice seeing so many people on the call as well. So that's nice. And so, I'm definitely seeing a lot of neglect. I'm seeing a lot of exploitation. I'm seeing a lot of emotional abuse. And that is extremely consistent with national values. It's the invisible forms of mistreatment, the ones that have less outward signs, i.e., not a black eye, not someone who requires a sexual assault nurse examination or rape kit to be performed. It's the invisible stuff, the neglect. You might see outward manifestations of neglect if it goes on long enough, but you can't immediately see if someone doesn't feed the person they're in charge of or doesn't take them to the doctor. In fact, you might not see it because they're not presenting for care. Emotional abuse, you might see it happening in person, or it might be happening back at their home. And exploitation, until it's become severe enough that they can't afford to take care of themselves anymore, you might not see either. That's happening, in digital dollars moving around a lot of times. So this is very, very classic. So just a couple more alarming facts to get everyone to be engaged and understand why, but certainly I care so much about this. The vast majority of doctors have never asked their patients if they've been mistreated. It's not part of like a normal Medicare wellness exam. It's not part of a normal geriatric assessment for a lot of people. I don't know if any of y'all are members of the American Geriatric Society, but I get like their forum updates and a little nice tidy email every day in my inbox. And a while back, someone was asking about like what to include in a geriatric assessment. They were making a template for their, medical record. And people had all these great ideas and were sharing their templates. And it was really wonderful community action. But I was like scrolling through and not a single one asked about elder mistreatment. And these are like geriatricians and geriatric providers, like people who are more clued in than perhaps our internists and family docs, neurologists, psychiatrists, ER docs, whatever. Most of us aren't asking. And again, most of us have never asked or will never ask. And an APS study corroborated that. Less than 1.5% of APS cases come from physicians. So we're also not making the cases. Even if we are asking it, we're not making the cases. And again, we know elder mistreatment is incredibly prevalent and often unreported. So a lot of these numbers keep corresponding. And so when it comes to terminology, and for the sake of this presentation, I'll use the term elder mistreatment as an umbrella term to describe the various forms of abuses and neglects, as well as financial exploitation, because although there are small shifts in the community from what used to be published as elder abuse into elder mistreatment, if you do a lit search in this area, you're definitely going to want to search for elder abuse as well as elder mistreatment, because the terminology has been changing. And then you can kind of see a reiteration here on the side of like how common neglect, emotional abuse, and exploitation, again, the more invisible mistreatments are relative to the ones that kind of get like the airtime, if you will. These are the ones that we see when someone walks in, or we're part of the Me Too movement where sexual assault is happening. So again, visibility matters a lot in that. And I also like the umbrella idea because I really think we have an opportunity to be an umbrella to protect our patients from the mistreatment that could be raining down on them. So I think it kind of has a nice dual metaphor aspect. But in order to do that, we got to know what we're talking about. So what are we looking for in a general sense? Well, a lot of things. Some of them are change things that they cannot change, and some of them are factors that they can change. Um, so, certainly your age, your sex, your race, these are things that they, really can't do anything about. Socioeconomic status, unfortunately, for many older adults, changes as they become dependent on a fixed income. And so that really impacts, their options and their ability to, make choices to protect themselves. So not having adequate funding or unstable housing or an unstable food situation. Um, Being physically or cognitively dependent to any degree increases your risk factors. One, because you might not be able to cognitively plan how to get away from a situation, or you may not physically be able to escape a so-called perpetrator. So you kind of get stuck in one way or another. Additionally, if there are caregiving factors, either on the caregiver or the individual, the patient's side, that can like they've lived through a trauma or they come from a family that deals with things in a more violent way, if there's substance use on either side, and also just how long a caregiving relationship goes. I mean, there's caregiver burnout. There are many factors that can make this worse. And, part of it is also, the understanding that, again, APS uses, at least in Texas, the term alleged perpetrator and alleged victim. And I really don't like either of those terms because I think assigning a victim status is, not helpful for growing and overcoming. But I also think calling someone a perpetrator is not really accurate in most cases. I think very few people, in my experience and just kind of my general beliefs about humanity, I think very few people set out to harm someone. I don't think they go into this caregiving relationship with the goal of harm. I think a lot of factors come together to produce neglectful or abusive behaviors in a person that is under resourced, doesn't have enough time, doesn't have enough money, just doesn't have their own psychological health or enough support. And none of that's to excuse what they do, but it's also to recognize that this isn't happening in a vacuum. And the other thing that can make it hard, again, even for the best caregivers out there, is when someone is having so-called, behaviors or psychiatric symptoms of dementia or mental illness, whether that's agitation or aggression, that can make it very hard to be a caregiver for that person. Not literally because of potential physical danger to the caregiver in caring for someone who might be spitting or kicking or punching or scratching because they're scared. But I recently heard it described instead of neuropsychiatric behaviors, but as manifestations of suffering that that individual might be experiencing because of their own cognitive impairment. They might, and probably reasonably are, scared, confused, overwhelmed, and lack the tools to express that in a more productive way. And so I think it's important to remember the humanity of the people that we take care of, and of the people that are taking care of them as well. And without getting into it in great detail, you'll see that many of the risk factors for the caregiver, and the caregivee, if you will, are very, very similar, and they circle around the same themes. It is important to note that the people who are most likely to be exhibiting these neglectful or abusive behaviors, most of them are people who have access to the individual. So it's not strangers, it's not the boogeyman in the streets, it's family members or nursing home workers, because they have literal access. Like they, unfortunately, they have opportunity. They also bear disproportionately the stress of the caregiving. And it's pretty alarming to know that 2/3 of nursing home workers admit to mistreating people because, again, those are just the ones admitting it. And if, 67% of people are willing to admit it, it makes you wonder if it's really much, much higher. But certainly not having support, having your own, you know, challenges in your life that have made it more difficult for you just to be a person, much less a caregiver, all of those make it harder to be a caregiver. And I have a colleague in our nursing school who does a lot of research on this. And one of the things she found was, that like a couple things are like protective, but one of them is getting enough sleep. Anyone who's ever been a parent knows the impact of sleep, or rather not enough sleep, on how much you feel you can cope with during a day. That doesn't change when you're a caregiver of an adult. And also having meaningful and joyful experiences with the person you're caregiving. Those matter too. But not having those and having bad things certainly makes it more risk of mistreatment occurring. And so what happens when mistreatment occurs? Well, certainly increased incidence of acute and chronic exacerbations of health conditions. Um, Older adults, the idea of frailty is that you have a harder time maintaining homeostasis, especially when there is, an internal or external stressor. And so obviously elder mistreatment is a pretty significant external stressor. Being neglected means you might not be getting your medications that might help keep you from having an exacerbation. And basically, and just being older, unfortunately, in general, makes it harder to stay kind of in that healthy range. The littler things will tip you over into an exacerbation than maybe prior when you were younger. And so this constellation of, not getting what you need, not being taken to the doctor, living in a psychologically or physically stressful environment, all of that makes it more likely that you're going to wind up in the hospital or the emergency room or have a stay in rehab or a nursing home or something similar. But wrong way. Additionally, it's incredibly expensive in the United States, somewhere between 3 and 36 billion with a B dollars are spent annually related to elder mistreatment. The range I know it's an order of magnitude going from 3 to like over 30 billion. That difference has a lot to do with how kind of the health economists calculate it. Um, if I, make X amount of dollars as a physician and then I quit my job and become a caregiver for someone else, unfortunately, society deems my value a lot less and my paycheck would go down pretty substantially. And so the gap between my physician salary and my new caregiving salary, if I even have one, that economic productivity that is lost and all the downstream economic impacts, that is being calculated by some health economists when they're coming up with these numbers. Others are looking purely at like how much was given to a scam artist. How much did that hospital stay because of the physical abuse cost? So multiple different ways to kind of arrive at the same sort of information, but depending on what you include and what you don't include, you get a more or less broad picture of the economic impact and thus the cost. So my husband is an economist, not a health economist, but that was his explanation to me about some of that. So big difference, but please know again, regardless, we're measuring in the billions and it was preventable too. And on the subject of preventable, elder mistreatment produces a minimum of a threefold increase in mortality in the first year after it occurred or is occurring. It's higher than even that 300% increase initially, but by the first year, it kind of goes down to only a 3 times risk of death compared to your prior baseline. After the first year, it trickles down a little bit more, but it never returns to the prior baseline. You are always, as far out as the studies I've looked at go, you remain at an elevated risk. So again, a 300% increase or threefold mortality risk from experiencing elder mistreatment. And then, as I've talked about, the caregiver factors as well are enormous in many, many ways. So, for the next part of the presentation, I wanted to spend a little bit of time weaving more about each subtype of mistreatment into a story. It's a hypothetical story about a made-up patient who's kind of an amalgam of the patients I've seen over the last 6 or 7 years while doing this work. And then kind of as described, you'll see in the bottom corner some nods to the various M's of how, like, for example, if you are physically disabled and lack mobility, you may not be able to escape someone physically abusing you in the way that like I would attempt to personally. So just little nods again of signs and risk factors and consequences with those. But what is physical abuse? Well, as you will see in many of the definitions, intentionality and regardless of resultant harm are important parts of the working definitions that I use in the forensic, i.e., medical legal sense. So, from medical legal perspectives, intentionality matters. If I bump into someone while walking down the hall at work, and even if I cause them harm, I did not intend to harm them. I just am a bit of a klutz sometimes, and I ran into them and I hurt them, but that's not physical abuse. So the intentionality of using physical force against someone else, you can't abuse yourself, in this context, is a big part. Whether or not you use an object or just your body or, something else, that part doesn't really bear weight. You can use an object, you can't use an object. And again, regardless of whether or not someone gets hurt. And that was kind of the point I was trying to make earlier, that again, like if I were to try to physically abuse someone and they just didn't manage to get hurt by my attempt, that doesn't really matter because I intended to do it. So intentionality and regardless of resultant harm are reoccurring themes. And this is kind of what you would expect. I think people have a fairly decent understanding of physical abuse. This is scratching, biting, shooting, burning, hitting, slapping, restraining, pulling hair, harm. But it also includes things like force feeding. Now, in a patient with advanced dementia where the family keeps putting food in their mouth in the effort to try to nourish them, I'm not going to make an APS report. I'm going to have a conversation and say like, hey, they're not accepting and swallowing the food you're giving them because of their disease process. We don't recommend it. If they are not receptive to being fed right now, you don't need to do it anymore. And I'll have a conversation. If it persists or it's violent in any way, that's a different story. But sometimes it's, opportunities to provide guidance on, no, the perineal care does not need to be quite so rough and vigorous. You can do it in this way. And again, providing teaching, but if it persists, it's a very different story. And when we're kind of like getting this information from people, we're looking for stories perhaps that don't make sense, like saying, oh, well, I got this black eye when I fell down the stairs. Like, okay, maybe, but that doesn't really fit. Or, oh, I ran into the doorknob again. Well, why were you at the level of the doorknob? Um, or if they just can't tell us anything about it or are unwilling to. Um, in general, injuries that are kind of in the middle of the body or the head and neck are unusual and consistent with physical abuse more often than not. Um, Accidental injuries are more likely to occur, kind of on like the extensor parts of the body, like your shins or your knees or your elbows or kind of like the back of your forearm. Whereas injuries to like so-called squishy areas, your stomach, your chest, your back, your buttocks. I mean, maybe a good fall will give you a nice butt bruise, but in general, those aren't places that accidentally get injured, with the one exception of defense wounds. If someone were trying to strike me in the head, my protective instinct would be to raise my arms over my head or maybe curl in a ball, but basically expose that same flexor or the same extensor area. That's like the one exception. So again, the story matters, the mechanism that they're describing matters. Oops, sorry. And similarly with sexual abuse, it's an intentional act. It has to involve another person, regardless of whether or not there is harm or even potentially, like physiologic responses that might mimic enjoyment, such as an orgasm. None of that makes or breaks it. If someone intended to sexually assault you in any way, whether or not it caused harm and it involved another person, that's rising to the level. And then the key here is consent. Was consent given enthusiastically and not withdrawn? Or is it an individual who, because of their cognitive impairment, cannot consent at all? They are consent incapable. And so when we're looking at signs, if I have a patient with advanced dementia who is minimally verbal and they have a new STI or the presence of, semen or some other biologic material in an orifice or on them or on their clothing, that's rape, like just de facto, because if they cannot consent to it, it doesn't matter. Again, even if they show physiologic signs of potential, what might be classified as enjoyment or at least stimulation. And then we also are looking for injuries in areas that might be involved in sexual activity. And again, you got to think broadly. People engage in a variety of activities, so it's important to, be thoughtful and broad-minded there. But it's a whole range of things ranging from, rape and sexual assault to including human trafficking, taking pictures or videos or sending pictures or videos that aren't wanted, or even just offering favors runs the risk of that quid pro quo. I think a lot of people do like Title IX and Title X training as part of work, that kind of idea. And mentation matters because of the consent aspect. So now it's time for a little more interactive. I'll tell you briefly about this case of Mr. Blythe. And if you have it up on your phone or device, you literally can just kind of drop pins on it by clicking or tapping, depending on your device, so like you could just click on any part that you think might be related to physical neglect. So if I were playing this game, I might find the fact that he is unshaven and thin as a possible sign of neglect. So you can click and drop a pin there as we go. And it might take a slide or two to get the hang of it, but I see someone's got that. Here we go. We'll go back to the image so I can read it and then I'll do that. But yeah, we've got this hypothetical male patient, Mr. Blythe, we'll call him. He's 83. He is recently widowed. He is a white male veteran. He used to be someone who was very fastidious about his person and his home, that military aspect. And he shows up to the emergency department, a couple mornings ago. He's having a rough time. And he's got a history of diabetes. He's got atrial fibrillation, on anticoagulation. He's got hypothyroidism. And this all kind of came to light when his daughter video chatted him over the holiday to kind of have a little like distance family meeting, or meal. And they found that he looked thin, unshaven. He was wearing multiple jackets. And even though she'd like sent him food, just to be nice, he was eating soup out of a can, which either means he like opened the can and just started eating it and didn't even bother to cook it, or he shoved the whole can in the microwave and blew up his microwave. So something bad happened. But she's definitely alarmed at how he looks. And based on all the dots and on the picture too, great. You guys are seeing the same thing. His clothes are in disarray. He's, all the concerns. He didn't look good. So let's see what happens next to him. So she, comes down to Houston in this case to see him. And again, we're still looking for physical neglect on this slide too. And she comes down to see him and she gets to his house. And again, remember, he was like a neat freak, the type that like folded his underwear, like really organized guy, in his prime. And now his home, it's cold, it's dark, it's like the electricity's off, and there's like second notices for unpaid bills that have now clearly been disconnected. It looks kind of hoarded. There's like food and bugs. His fridge is pretty empty. He's not managing his trash. Um, he also the pants he's wearing have some staining around the groin as if he's had an accident or two or more, which is also not normal for him. Maybe he's got some, UTI process going on because he's a little, confused as well. But yeah, things just like look really bad. And I think by the number of responses, yeah, you guys are definitely seeing what I'm seeing. Apologize if you have a big screen and those cockroaches look extra large to you. I once gave this presentation on a very, very large projector and those cockroaches were like uncomfortably large. So apologies. But yeah, you guys are doing great. And so now instead of just pure neglect, we're going to look for mental health neglect. And thank you guys so much for playing along. This is awesome participation. But yeah, so now his daughter says, okay, enough is enough. We're gonna go ahead and go to the ER. And when he gets there, the ER nurse is checking him out and kind of getting the history. And the daughter says, yeah, like dad hasn't been himself ever since mom died about 5 months ago after, this long battle with leukemia. And, even though he's a little confused, he's with it enough to, engage with that. And he says, yeah, I really miss her wonderful cooking. I miss, game night with her. Now I'm just the fifth wheel. I'm bored. I'm hopeless. My life is empty. And, I've actually started taking two or three, multiply times three, but two or three, shots of whiskey just to fall asleep and drown out, hearing her voice, because I'm still hearing her. I know I'm hallucinating, but I hear her. And yeah, it concerns him. So he's trying to manage it, but maybe not in the best way. And yeah, exactly. You guys are seeing the signs. I don't know if you guys use the geriatric depression scale in your clinics and areas, but some of these, the feeling empty, the hopeless, the boredom, all of that is pulled right from the geriatric depression scale, which if you're still using a different depression scale for your older patients, like a PHQ-9 Patient Health Questionnaire 9, strongly recommend the GDS geriatric depression scale because it really hits at the psychological symptoms of depression and less on the somatic ones, that are, things that our patients might be experiencing anyway, like appetite changes, sleep changes, appetite, sleep, kind of how they move around in the world. Like some of those are just unfortunate, either parts of getting older or part of a disease process they may already have, maybe a medication side effect. But the GDS really hits on the emotional symptoms that are less likely to be due to something else. So yeah, great jobs there. Um, okay, and if we go on to the next one, we're going to now look for some medical neglect. And I promise I'm going to come back and tell you all about these in, I think, the next slide. So yeah, the nurse is still kind of doing the intake. Good geriatric, nurse there reviewing the medication box and doing a comprehensive medication history to help reconciliation later. And she notes, it's still full to Sunday and it's a Tuesday, so he hasn't taken Sunday, Monday, or even Tuesday meds yet. And he says, yeah, whatever, I forget. I haven't been to a doctor since COVID. Like, who cares? So who knows how old these meds are? He just kind of takes them if he wants and doesn't really know what they're for, but, is what it is. And even though the daughter was there, he didn't, think about bringing his glasses or his dentures. And, he has evidence on his body of, some poor grooming, with kind of long, dirty fingernails. And so kind of a little frightful there. And then, the labs start coming back and, we see with this history of hypothyroidism, he's clearly not taking his meds. His TSH is really high. His diabetes is not under good control, even with, relatively more lax guidelines for older adults. His kidneys maybe are a little bit dry, maybe he's a bit dehydrated or something like that. And also he's on warfarin for his atrial fibrillation, or at least he's supposed to be, but he has a normal INR, which is not what we'd expect. So, that's why that medication history really matters, because that would otherwise get overlooked. But a lot of evidence he's possibly not taking his medications, as you all expertly identified. Wonderful. Wonderful. All right. So now that you've demonstrated your expertise, I'm going to just follow it up with, some quick, information about it. So self-neglect is when you basically don't fulfill your own care obligations, even if whether you intend to or not. I can make a choice today to stop showering and stop going to the doctor and, all those things. I can make that as a choice as an adult with capacity. That is, I make that choice with intent, understanding the consequences are not good. In people with, cognitive impairment or severe psychiatric disease, a traumatic brain injury, any number of things, they may not be making that as a choice, and it may be a consequence of their inability to still have the executive function and the executive capacity to do these things, or just simply to make a decision, because there is a big difference between making a decision and carrying it out, or so-called decisional capacity and executive. And I think a lot of our patients still superficially have decisional capacity. I think what lacks for many is executive capacity, and that's the part that we often miss when we're kind of doing that. Can they decide this? Many people can decide it. My children can decide they want waffles for breakfast. I'm not always confident they know how to do all the steps required to get that done. And that's why minors don't have capacity for most things for a while. Unfortunately, without meaning to infantilize some older adults, the same can be true with certain disease processes. And as we saw with Mr. Blythe, this is demonstrated both in the examples and signs by failing to arrange for these important areas: food, clothing, shelter, health, safety, finances, your ADLs, your IADLs. And that causes the consequences we see, the signs of pressure injuries or dentition that is poor and unmanaged. Maybe they're covered in bites or rashes, due to hygiene or infestation concerns. Maybe they don't have the medical supplies. Maybe they're not trimming their nails or showing up with their dentures in the emergency department. Any of those things that we saw with Mr. Blythe can be a factor, or just because of the lack of care, they can have cognitive changes, confusion, delirium, depends. But yeah, and as you can see, all the 4Ms are deeply involved in self-neglect. Not having adequate mentation or mobility can impact your ability to take care of yourself and to do the things that matters most to you. And certainly, especially on the medical neglect side, medication comes in for mental health and medical neglect as well. Um, So this one, you don't have to click anything. This is just kind of a summary of, where we've been. Basically the ER, it's Jerry friendly. I love when that happens, the age friendly ER. And there in this is an acute care for elders or elderly unit, an ACE unit. And so they do some cognitive testing because they know that mistreatment subtypes are connected. If you have one form of mistreatment, you're at higher risk for another. And so they kind of do some preliminary cognitive testing, knowing that they might not be diagnosing anything today, but just to get a sense of where he is. And the reason they do this is because screening is so important. I know I started off my presentation talking about that, and that's why I share kind of all the very alarming and real statistics because I want people to have buy-in from the first few slides. I want people to understand this is important and everywhere, and it's our job to know and care as physicians, not just as, maybe geriatrically inclined people, but just as physicians and nurse practitioners or PAs. I'm not exactly sure who all is on social workers. We all have a role in this. Even EMS can put in an APS report, but screening for elder mistreatment when they are in a healthcare setting, whether that's our clinic or a hospital or an ED or a facility, is so important because for that brief moment in time, they are a captive audience, maybe away from the person perpetrating the mistreatment to them. In that moment where they are safe and cared for and maybe eventually at their cognitive best because their needs are actually being met, we have them as an opportunity to ask and intervene. And when they leave our clinics, hospitals, etc., they're gone and we may never get them back depending on the form of mistreatment happening. So when and every time they are with us, it's an opportunity to ask. And it's really low hanging fruit, but it's a huge quality indicator because we can meaningfully intervene and prevent harm, even if we can't prevent the mistreatment itself, but it can prevent the other consequences we talked about. So even though this is now like a 10-year-old article from the Journal of American Geriatrics, I always have to bring it up. And then talking just about screening, there's a lot of tools. There's no gold standard. Each of the tools comes with different criteria about where you should use it and how cognitively impaired or not the patient is allowed to be, and I like the easy screen because it's 5 questions that you ask, one that you observe. It's yes or no. It just gets the conversation started. If someone shows up to you and says, hey, doc, hey, whomever, I have foot pain, you're not going to go cool and move on. You're going to dig a little bit about that foot pain and learn more about it. And that's the same thing with elder mistreatment. You just want to start asking questions to open that conversation because it's probably something, if it's happening to them, that they desperately want to talk about. Or maybe they know someone it's happening to and they're the informant that can help you by proxy help someone else by encouraging your patient to make the APS report for someone else. Like, I mean, again, we live in a community, we're all interconnected. So this is one tool. Again, there's no gold standards. This one is literally just easy. It's validated in the outpatient setting, but again, just starting a conversation matters. But yeah, it's called the Easy Screen. This is one that's used in emergency departments and that I'm piloting in our acute care for elders ACE unit down in Houston. And it seems really, really, really long, but it's only 3 questions and many observations on the pre-screen. And all of these are optional if available, if you have access to this information. But basically, if any of these are yes, you can consider doing the full screen, or what I recommend is consider just going ahead and making the APS report because all you need is a suspicion. And then again, just another tool, that has been used by EMS that I'm currently doing research with the PI, Brad Cannell, on, and some of my other colleagues, Jason Burnett as well, in Texas to transform this into a house calls tool for people visiting people in their homes. It used to be for emergency medical services to use, but now we're adapting it. So lots of tools, many, many, many more than this. I know we're running a little low on time, so I'm going to keep going. Basically, Mr. Blythe gets treated for his conditions and starts improving. Turns out he did have a UTI. He's getting better now, but his daughter's really worried about the idea of him going back home based on how she found him. And so he compromises kind of grudgingly to have an in-home caregiver. And so now is the time we can play along again. So he's settling in now back at home with his new caregiver. And again, he's like a military guy. Like he's tough. Maybe he was like a colonel and he didn't take flack from anyone. And so it strikes his daughter a little bit that he remarks that the caregiver has a strong personality because, she's like, Dad, you have a strong personality. Like, what are you talking about? And then it kind of escalates, and over the next couple weeks, there's more signs that make her nervous, and perhaps you too, as you click for caregiver neglect or emotional abuse. And so he makes this like hurried voicemail to his daughter, like she's been too busy to take me out and take me the places I want to go. And she's kind of like isolating me, says that I don't need anyone but her. And he's like mid-story when all of a sudden he just disconnects the phone, almost like the caregiver walked into the room. And the daughter, of course, much as y'all is like seeing the signs on the wall that y'all have so expertly marked and is like, man, Dad, like, what's wrong now? Something bad's happening. So she's worried for emotional, psychological, or verbal abuse, which is someone intentionally using their words or nonverbal communication to try to cause harm, even if no harm results. And this is what we'd expect. This is the yelling at people, isolating, threatening, infantilizing them. And again, I know we draw parallels sometimes to developmental stages and loss of developmental stages in dementia. And it's important to understand that that's not meant to be like treating someone like a baby. Infantilizing is deeper than that and restricting and not giving rights that an adult has. um Berating, harassing, all these things, but again, isolating, and manipulating, being like, if you don't eat what I put in front of you, you don't get to see your daughter this afternoon. Like, no one has a right to say that to another adult. And of course, this can have significant impacts on, their mentation, how they take care of themselves, how they feel about themselves, how they socialize, and as the circles indicate, what matters most to them, it can impact. Additionally, caregiver neglect, or if it happens in totality and the caregiver does nothing and abandons them, that's kind of like the extreme version of caregiver neglect. That's the same idea that we talked about with physical neglect, but now it's being done by another person to similar consequences, except now, again, it's being done to them by someone who may also independently have risk factors. And it can produce a variety of responses. Sometimes it produces a generalized anxiety. Like if I were neglecting someone, they might become a little bit afraid of all white females because of that generalized fear. Or maybe they become extra clingy and almost Stockholm syndrome like picture because they're trying to ingratiate themselves to me, knowing that unfortunately I hold so much power over them. Again, a variety of things. We see this. I'm not a pediatrician, but I have heard that they see similar things in, child protective services where some children are like, get that parent away from me. I hate them. They're awful. And others are like extra clingy. So we see both sides. Um, and now, kind of on to the last part on financial exploitation. We'll look at that. And so this daughter, after that voicemail, she tries and tries and tries to get back in touch with her dad and can't. Maybe the caregiver overheard the conversation and now she's taking the phone off the hook. She's always answering on his behalf and saying, nope, he's busy, he's gone, he's this, he's that. You can't talk to them. And again, she's out of state. So she's like, crap, is, like his dad even alive? And so she shares an account with him. And so she gets on the account, to make sure that there's still like signs of life, credit card transactions or something. And the good news is she does in fact find financial transactions that indicate he is alive, but maybe not well, because he's been sending larger and larger sums of money to his caregiver to help her out and things that are not part of her paycheck. And as a consequence, he's running low on money, which is probably going to impact his care and maybe create some self-neglect in the future. So, as you guys correctly identified, again, wonderful interaction. I'm really appreciated. Lots of concerning features here for financial or economic abuse, but most commonly called exploitation. And that's when you intentionally use someone's funds, assets, property, resources belonging, like their stuff, without their permission, illegally, or in a way, even if they give you some permission, if you use it in a way that's not authorized, regardless of whether they are harmed by it. So if I take a dime from Bill Gates or a dime from someone who is unhomed and has no money, both of those are exploitation. I don't have permission to have either one of their dimes, and it doesn't matter how much. That's the idea of skimming. If I'm a caregiver and they give me their credit card to do their grocery shopping, and I also get a gallon of milk for my family on their credit card, I'm skimming a little bit off the top, like you'd skim cream off milk. Same idea. But it's also the big ones, the scams, the fraud, the creating powers of attorney or other documents without permission, opening new lines of credit, using someone's age or disability against them, things like that. And we see that in, maybe these new friends or partners that kind of crop up, often with an age differential from our patient. Maybe they aren't caring for themselves in the same way because now they don't have the money to. Maybe a will that had been long standing all of a sudden is changed unexpectedly, or items are going missing or not returned. And so ultimately, this is a very busy slide. So I'll go ahead and highlight the three important parts of what our role is. And this comes from the same article that I talked about earlier about how measuring and evaluating for elder mistreatment is a quality improvement, and a quality measure. And so our most important role as clinicians and people that interact with older adults is to, one, continue to support them. We don't make an APS and then flee into the night. We stay by our patient's side and help them. Maybe not coordinate the APS response. That's literally APS's job. Our job is to be with them and to report our suspicions. I always recommend telling patients that you or I am making a referral to APS to provide additional support. I tell my patients if I make a cardiology referral, I tell my patients if I make a social services referral, because they are the experts in managing this. So unless you do this for a living like me, APS is probably going to be the one with the expertise and the time, the skills, the services to help manage the consequences of elder mistreatment and prevent it in the future. So I consider them a colleague that I make a referral to, and that's how I explain it to my patients. And so all I did to find the North Dakota APS was Google North Dakota APS. And so it did come up with this website. And I believe the slides did go out. So you should have this that you can explore. And it kind of talks about various ways to do it, either online or completing a paper form, or calling. So North Dakota comes with lots of options. That's wonderful. Not all states have that. And for whoever's on the call, here is the list of mandatory reporters, but they do note that these are the ones that have to do it, but everyone on the planet should report elder mistreatment if they encounter a suspicion of it. You don't have to prove it. You don't have to investigate it. You just have to have that feeling that keeps you up at night or sits wrong in your stomach while you're talking to them. That's enough to report. Most states I didn't feel like digging into the legal code, to be honest. I'm not a lawyer, but the vast majority of states have if you make a good faith report, even if it winds up being not accurate, you're protected from civil and criminal liability. So don't worry about making a report that you're not positive about. It's important to make the report and turn it over to the experts so they can do their own investigative work. And if you don't do it, there are consequences. So it's better to make a report in good faith than to have a consequence of not. And on that note, I have a little summary there, but the take home is it's important to screen, it's important to report, because it really is all over the place, more than we really realize, and the consequences are extremely real. to society, but probably more relevantly to our patients themselves. And those 4 M's can help us understand some of the risk factors and why it matters and why managing it matters most to our patients. There are some references